Good afternoon. This is a very simple topic, and as usual, I keep the things very simple for practical purposes and, of course, for exams. So it can be an interactive session, and you can ask any question whenever you like. So broadly, I'll be talking about what non-invasive ventilation is, what is the physiology, how it is maybe more advantageous than the invasive ventilation. Then what are the complications, and in various disorders, in various diseases, what could be the possible settings. And then also I'll talk about the recent guidelines, and maybe those guidelines are very useful for you. So just move on to the topic. So non-invasive ventilation basically provides a window of opportunity where it may avoid the use of invasive mechanical ventilation in substantial number of cases if appropriately selected. So that's the beauty of it, and that's why this topic is very close to my heart. The non-invasive ventilation in India started somewhere in 1996, and then it has really taken off, and now practically every ICU has got this facility. So what it does is it supports the ventilation without an invasive airway. So it's being applied without any conduit to the airway, like there is no endotracheal tube, there is no tracheostomy, it is outside. So it is non-invasive. That's why it is called invasive. Invasive ventilation is when you access the airway by a tube and then connect it to the machine. That is invasive ventilation. And the other thing is that it can be applied in various settings. It can be applied in ICUs, it can be applied in SDU, it can be applied in the wards, and it can also be applied in home care. So that's the beauty of it. And large number of patients are on non-invasive ventilation at home. So that is what it is, and many times even the patient's attendants can be trained in using the non-invasive ventilation. So it is very, very simple to use, but it has to be used very, very appropriately. That is very important. So let's discuss some of the terminologies associated with non-invasive ventilation, like BiPAP. What is BiPAP? BiPAP is a machine which delivers two pressures, a pressure during inspiration, the pressure during expiration. That's why it is called BiPAP, right? Bi-level pressure device. Now, what is IPAP? Is the pressure which is delivered during the inspiration. That is the IPAP. Okay. The EPAP is the pressure that the machine delivers during the expiratory phase. So that is the EPAP. Alright, so naturally the IPAP would be always higher than the EPAP. IPAP cannot be lesser than EPAP. And even if your machine set IPAP lesser than EPAP, it will continue to deliver EPAP, because that the inspiratory pressure can never be lower than the expiratory pressure. Alright. Then the trigger is the starting of the inspiratory phase. So when the machine goes from expiratory phase to inspiratory phase, that is called a trigger. Alright. Then comes the cycle. When the inspiratory phase stops and the machine goes from IPAP to EPAP, that is called the cycle. So what we call as the BiPAP has cycled off to EPAP. So what it means is the IPAP is stopped, right, and now it has gone into the expiratory phase, that is, it is delivering the EPAP. Then the rate is simple. What rate you set on the machine, right? So it could be any rate that you can pick up from, maybe 10, maybe 15, maybe 16, depending on the clinical condition of the patient. Alright. There is the inspiratory time. Inspiratory time is how long the BiPAP or the machine remains during the IPAP phase. That is what the inspiratory time is. Then the rise time is the time that the machine takes to go from EPAP into the IPAP. So that is the rise time. So this is something which is very interesting, and I'll talk about it, rise. And every time people ask, what is the rise time? How does it help? What is the benefit of setting the rise time? It has some importance. Then the sensitivity refers to the triggering and cycle of the device. So you have to set a sensitivity, like in invasive ventilation, you have a pressure sensitivity, or you got flow sensitivity. Similarly, this machine also has a sensitivity, and mostly the sensitivity is flow related. Okay, so it has a flow sensitivity. So when the patient generates certain flow, machine senses it, and the inspiration is delivered. The machine delivers the IPAP. And then what is the pressure support? Pressure support is the gradient between the IPAP and EPAP. So higher the IPAP, lesser the EPAP, more is the pressure gradient. And more is the pressure gradient, more is the tidal volume delivered. So basically, it's like pressure support ventilation that you have in your invasive ventilators. So let's talk about this and understand this by way of this waveform that we have. So this is the EPAP, right? This is the baseline pressure, this is the EPAP, and you can see this is the inspiratory. This is the IPAP, the higher pressure as it is there. Then this is the trigger, and then you have the cycle which is now marked there, where the IPAP is converting into the EPAP, and then you have got this rise time. Okay. Then you have got this rise time from from baseline when it goes into the achievement of the inspiratory pressure. Then this is the rise time. All right. And then what else we have? We have this pressure support. That is the difference between IPAP and the EPAP. And that is what we call is the inspiratory time, right? The duration in which the machine remains in the IPAP phase. So this is what the rise time is all about. So this is what it is. The rise time is how quickly the machine goes from EPAP to IPAP. Now I give you an example. If you are climbing 10 stairs, then what is happening is that you need volume, and you need volume very quickly. You are panting for the breath. So how quickly that you achieve that volume, it becomes very, very important. And that's why possibly in your case what you need is a smaller rise time. If your machine is set to give a larger rise time, you are not going to achieve that volume. So your body is not going to rest. And these things become very, very important, especially in case of COPD, because they are breathing hard, they want volume quickly. So in patients of COPD, what you do, you set a lesser rise time. You want the machine to convert trigger from EPAP to IPAP very, very quickly, because the patient needs volume, he needs pressure support, more pressure support. It may not be so important in patients with restrictive lung disease, like your ARDS patients or congestive heart patients, because they are already breathing very hard. So in those cases, it may not be very important. In those cases, you can keep a little larger inspiratory time, so that the pressure, the enough time is achieved for the gas distribution of the pressure, so the tissues or the lung alveoli are adequately or appropriately ventilated, right? But in a patient who is at a high rate, say 30, 40, like your ARDS patient, then this rise time doesn't make any sense. So the only sense that it makes in patients with COPD, where you want to set a smaller rise time. So that is the important thing that you have to remember. Alright. Now coming to the indications. BiPAP is basically a ventilator. So when there is a ventilatory failure, it will not help too much in a hypoxic respiratory failure. It's a ventilator that is going to work when the patient has got a hypercapnic respiratory failure. Now, who are the cases who come with hypercapnic respiratory failure? The chronic obstructive lung diseases with COPD exacerbations. Right? So these are the cases who go into hypercapnic respiratory failure. Their SO2 would be 60, 65. They may be oxygen saturation, say 50%, but you give 1 liter of oxygen, the oxygen is very much maintained. You don't have any problem as far as achieving adequate oxygenation patients COPD. Absolutely no problem. 1 liter, 2 liters oxygen maintained. But the problem is they are hypoventilating. Right? So there you need a machine, and there this machine really comes to the picture. So one foolproof, the proven indication of BiPAP or non-invasive ventilation is when there is COPD exacerbation with hypercapnic respiratory failure. Then many patients with neuromuscular disease and chest wall deformities, because they are again hypoventilating, so it will be useful. Acute bronchial asthma is something tricky. Right? These patients do not have a problem of ventilation. These patients have a problem basically bronchospasm. They need bronchodilators. They want relief of their inflammation. So ventilation is not much of a problem. And if you apply something like that, they generally do not tolerate. So in bronchial asthma, exacerbation, you can try, but you have to be skeptical, and you may find that many times it may fail. But there is no absolute contradiction. You can try if a bronchial asthma patient is presenting with some sort of hypercapnia and in some sort of a respiratory failure. Then obesity hyperventilation syndrome is a definite indication. right? Many of these patients have a chronic disease, and these patients are home ventilation, where it is a definite indication as the chronic home care is concerned, and these may come with acute exacerbation. Many times these patients got associate COPD, they come with acute exacerbation, and then again it will be very useful. The cystic fibrosis while awaiting lung transplant patient and central alveolar hypoventilation syndrome, like you got the Picquian syndrome, that is of course can be used in chronic daycare setting. Now coming to the hypoxemic respiratory failure, the indication is the PF ratio is between 200-300. That is the early ARDS patients. It may be tried, right? But it has to be tried very, very carefully. As I said, BiPAP is basically ventilation, doesn't improve your oxygenation. All right, it can improve by its setting. IMPAP is there to improve it, but basically it is not to improve oxygenation. So in hypoxemic respiratory failure, it can be used, but with caution. All right, and whenever using in, say, in hypoxemic respiratory failure, it should be used only in ICU setting, because these patients can worsen and may require invasive ventilation. All right. Remember one thing: non-invasive ventilation does not wash out, right, or wipe out your invasive ventilation. You have to have invasive ventilation as backup in even case of COPD, even in case of ARDS, particularly in patients of ARDS. It has to be used only in ICU setting, not in the ward. That is very, very important. Because in hypercapnic respiratory failure or COPD, you can use it in the ward also, who are the patients who are stable. Coming to the indication hypoxemic respiratory failure, the cardiogenic pulmonary edema, there is a very strong indication, because it's a disease which quickly reverses. You give the decongestant therapy, and in 2 days time or 3 days time they're fine. So there it has really been found to be very, very useful. In ARDS patients, as I said, in early ARDS, stage 1 ARDS, you can use it, but with caution that the PF ratio is between 200-300. In thoracic trauma, definite indication is there, particularly the patients who are not very sick. You can use, and you may find that these patients may not need the invasive ventilation for a period of time. Community-acquired pneumonia, you can use it, but again with caution, only in the ICU setting. And of course, in do not intubate patients, the terminally ill patient, it can be used as a palliative care. And thoracic and abdominal surgery, of course, there is a confusion about it. Many of the surgeons would say, I have done a esophageal anastomosis. If you put a BiPAP there, the wound get dehiscence. Or somebody who has got the bariatric surgery, then they would say it is not required. But the fact of the matter, there is no evidence that if you apply non-invasive ventilation, it leads to the dehiscence of the anastomotic site. In fact, patients of bariatric surgery who got a obstructive sleep apnea, it is recommended that you must use non-invasive ventilation post-operatively, right? That's very, very important. What you do in bariatric surgery before you close, actually, they put liters and liters of water in the stomach to see for a leak. There's a lot of pressure is already applied. So it is just a misconception that why is non-invasive ventilation these patients can lead to wound dehiscence. If it is indicated, definitely you have to use it. So coming to the advantages, well, advantages are that there is a greater flexibility initiating and removing the mechanical ventilation, because it is outside, it is over the face, and you can just remove the mask, even though the patient is continuing to be in respiratory distress. Not like invasive ventilation. Once the patient is hooked on the ventilator, it can be only weaned off when his respiratory distress has, or his ventilation has improved. It can permit normal eating, drinking, and communication. One thing is very important: when the mask is on, right, please do not do it, because there is very high risk of aspiration. Okay, or if the patient is speaking, then it can cause air leak, and then this can cause discomfort and inadequate ventilation. So if somebody is made to eat or drink or talk, possibly it's very important that you remove the mask, remove the ventilator, and then you can allow him to do those things. The other important thing is preserves airway defense, speech and swallowing mechanism. That's very, very important, because once the patient goes on ventilator, then it bypasses the mucociliary clearance, and therefore, these patients are at high risk of ventilation pneumonias and the other things. So it avoids complications in the airway, artificial airways, like the risk of mechanical or ventilation pneumonias, and of course, the risk of ventilator-induced lung injury. Here again, I want to give you a word of caution. Like in patients of ARDS, you are using non-invasive ventilation. And if you are dragging it for a long time, then the studies have shown that if you prolonging non-invasive ventilation, then ultimately the patient may have increased lung injury. So there is a problem here. So please do not drag these patients on non-invasive ventilation, especially patients of ARDS that I am talking to you. Alright, because it causes more stretching of the lungs and more lung injury. So appropriate timing has to be there. If the non-invasive ventilation, particularly in patients of ARDS, is failing, or the patient is not improving, for sufficient over a sufficient period of time, they should be intubated, ventilated early rather than dragging on the non-invasive ventilation. It provides a ventilating assistant with greater comfort, convenience, and less cost than invasive ventilation. So that's very clear. And it also requires the less use of heavy sedation. But many times, or maybe sometimes, the studies have shown that you use dextromethorphan in a patient who is very agitated, but it has not improved the outcome of these patients. So, in my opinion, a patient with hypercapnic respiratory failure who is on non-invasive ventilation, avoid sedation as much as possible. And if this patient is too agitated, it's better to terminate non-invasive ventilation, intubate, rather than giving some sort of sedation. Because non-invasive ventilation is very much doctor intensive, right? You have to be on the edge. You have to be seeing this patient very regularly. You can't leave these patients, at the mercy of the sister. Like if you intubate the patient, you're pretty well. Right, sister taking care of everything, but non-invasive ventilation you have to be very, very careful. So as I said, invasive ventilation is sister-oriented, but non-invasive ventilation is doctor-oriented. With a lot of decisions you have to make which the sisters cannot, make on bedside. Now coming to the selection criteria, we have to understand what are the absolute contraindications. Comatose patient, until there is a DNI, right, do not put them on non-invasive. They will aspirate and die. Cardiac arrest, absolutely no indication for non-invasive. They have to be intubated immediately. Nothing doing, no non-invasive ventilation. Respiratory arrest, maybe if it's due to, vasovagal or something, that's okay, right? But the patient has to be intubated. Any condition requiring immediate intubation, right? Then patient coming with a CO2, 150 or COPD exacerbation, is better to intubate rather than waiting this patient on non-invasive ventilation. Relative contraindications like cardiac instability, shock and need for pressure support, ventilatory arrhythmias, complex acute myocardial infarction, I would possibly prefer to put this patient on invasive ventilation rather than risking their life on non-invasive ventilation. Unless your team is very much strong, geared up, sitting by the bedside of the patient and monitoring the patient very, very, judiciously. Otherwise, these are the patients that my preference should be on invasive ventilation. GI bleeding, intractable emesis or uncontrollable bleeding, these are again the indications where possibly invasive ventilation is better than non-invasive ventilation, because again there is a high risk of aspiration. The patients die of aspiration. It is not the amount. It is how much, the choking, how much the patient has the ability to clear his airways. That is very important. Okay, so it may not be the patient has a mild hematemesis, right? If the patient has continuous hematemesis, there is a very high risk of aspiration, because these patients have comorbidities. They've got poor lung reserves. So even a small amount of blood can choke them, right? And many times these patients can go into laryngeal spasm, and that can cause negative pulmonary edema. This again is a lactatory problem. This basically presents like ARDS. So possibly these are the patients, even though it's a relative contraindication, possibly these are indications for invasive ventilation rather than non-invasive ventilation. Now coming to the various interfaces, I don't want to discuss too much about it. It's a topic on its own. You've got the full face mask, or what we call as the orofacial mask, the nasal mask. They've got their advantages and disadvantages, but in critical care setting, you start with the oronasal mask because you don't want leaks in these patients, and as the patient becomes stable, right, is more comfortable, then and going into chronic care, maybe shifting the ward, the time of shifting the ward, you put them in non-nasal mask rather than the full face mask. So I don't want to discuss too much about it. Now let's come into the modes of non-invasive ventilation. The first mode that is there is the time mode, where you set the rate, okay, and basically ventilator is delivering all the breath. There is no patient spontaneous breath. This is possible only the ventilators that we have. What you do is you put them like assist control mode, in pressure control mode, or maybe you've tried volume control mode. Fix the mask with non-vented mask and try and use them, right? But if a patient who is requiring timed non-invasive ventilation, again these are the patients who should be on ventilator rather than trying or fiddling with these patients. Intubate them, put them on assist control, and when they are fine, maybe then wean them off on non-invasive ventilation. So what is basically NIV is made for those patients who can breathe spontaneously, adequately, appropriately, little bit, right? Not the patients who will have required time breaths, or who are hypoventilating so much that they cannot breathe, they cannot trigger the ventilator. So that is something which is very, very important. And you got the ST mode, which is like SIMV mode, right? Where you set some mandatory breath on the ventilator, right? And there's some these spontaneous breaths. Now this differs from SIMV that you have. In SIMV, whatever mandatory breath you set, the ventilator would deliver. right? And the patient can also have his spontaneous breath, and then the total rate becomes the sum of the mandatory breath which is delivered by the ventilator and the spontaneous breath. For example, if you set SIMV rate of 10 and patient breathes at a rate of 8 on his own, then the total respiratory rate of this patient would be 10 plus 8. Whereas in non-invasive ventilation, if you set a rate of say 14 and patient is breathing at a rate of 16, then only 16 breaths would be, his respiratory rate would be 16 only. If only his rate falls below 13, then 15 breaths would be delivered. So basically in ST mode, in non-invasive ventilation is a backup mode. Alright. It does not add on to the spontaneous breath of the patient. That is very important. If the patient is breathing at a rate of 20, then his respiratory rate would remain 20, and this 15 set on the NIV would be redundant. So that is something which is different, and you have to remember. That's why in non-invasive ventilation, you always set a rate of 16, 17 or 18. You don't set a rate of 8 or 10. That doesn't make any sense. Whereas in SIMV, you can set a rate of 6, maybe 8. Alright, so that is the difference. The other difference between non-invasive ventilation and the pressure support ventilation that you have. In pressure support ventilation, if you apply the pressure support, it is above the PEEP. So if your patient has got a pressure support of 10 and a PEEP of 5, that the pressure control or the total pressure of this patient would be 15. 10 plus 5 is 15. Whereas in NIV what happens is the IPAP swings from the baseline and also the EPAP swings over the baseline. So if you set a pressure rate of the IPAP of 10 and EPAP of 6, then the pressure support would be only 4. Your high pressure would not exceed the IPAP. So that is something again which is different in the non-invasive ventilation as in the invasive ventilation. So this is something that you have to remember. So what you do ideally is that you put this patient on ST mode in ICU. Never start patient on S mode. Always put them ST mode because you want a backup rate, and always set it at 15, 16 depending on the condition of pain. Do not set ST mode less than 15. That is very important. Now coming to the spontaneous mode, when all the breaths are spontaneous, the patient is triggering the IPAP quickly without much of a discomfort, right? The breath is very much synchronized, and this would happen only in stable patients. That you can advise in home care setting, right? But in ICU setting or maybe in the ward setting, it's better to put these patients in ST mode. Now coming to CPAP, CPAP is when IPAP is equal to EPAP. Okay, so CPAP is basically like, one pressure. There is no pressure gradient between the IPAP and EPAP. Is not a pressure support. So CPAP is not a ventilator. The whatever tidal volume the patient generates on his own, it is not assisted by CPAP. Okay, so that is again important thing. Now coming to the functions of EPAP. Now EPAP functions like PEEP. So what it does, it helps in alveolar recruitment. It opens up the terminal airways and it prevents atelectasis. It may improve the VQ mismatch. Okay, so that is the function of EPAP. And it also stabilizes the upper airway during the sleep. So EPAP has many functions. It reduces your auto PEEP. It improves your atelectasis. And it also opens up your upper airway. So patient of obesity hyperventilation would always have obstructive sleep apnea. You will set a higher EPAP. A patient of COPD who has got a dynamic hyperinflation, who has got a auto PEEP, he has a problem of triggering. So what is happening is the air is trapped, the diaphragm is slowing down, so he cannot trigger. So what it does, it improves or it improves that auto PEEP which is there in the COPD patients, and this is how it is set. So what you do, you set the EPAP in a way that the patient starts to trigger the machine. You can see now the inspiratory phase is coming up. How it is done? What it does is it opens up the terminal airways. Suppose your auto PEEP is 10 or maybe 8, then once you set the EPAP of 6, it opens the terminal airways and the air gushes out, and then the diaphragm go up and the patient is able to breathe in. Patient is able to trigger the machine. Alright, so that's why it has a very good function in COPD patients. Okay, in ARDS patient there is alveolar atelectasis. Terminal airways are closed, so it is opening that. So EPAP plays a very important role in different settings. Sleep apnea patients, obesity hyperventilation, it's opening the upper airway. Whereas the IPAP, it has only one function, that is to unload the respiratory muscles. The function of IPAP is to deliver the tidal volume. That's why you set the IPAP over the EPAP depending upon how much volume the patient needs. How much of a volume patient would need, you would judge by his diaphragmatic movement. If the paradoxal movement is gone, it means the diaphragm is now functioning. That is the tidal volume he needs. Reduction in the respiratory rate, improvement in the tidal volume, Okay, the improvement is excessive muscular respiration. Right, so these are the criteria by which you understand that the patient is requiring IPAP and his IPAP is adequately set. And when it is delivering a tidal volume, it is also helping washing out of the CO2 levels. So you find the CO2 levels are coming down. Alright. So IPAP may not be so important in patients of hypoxemic respiratory failure or say in congestive heart failure patients. IPAP would be useful only if the patient has got hypercapnic respiratory failure, which occurs in patients COPD, obesity, hyperventilation, neuromuscular disorders. I think you understand that? So how do you start non-invasive ventilation? So as I said, first thing is to correct oxygen. So you start with some oxygen liter, 2 liter or 3 liter, right, by the nasal prongs, okay, or there is a port where you can attach the oxygen in the BiPAP, but initially put the nasal prong, do not attach the BiPAP. That is very, very important, okay. So first I will talk about the ventilator setting and then how to initiate it. So first thing is to choose the correct interface. Correct interface in most of the time would be an orofacial maze, which is covering the mouth and the nose so that there is no air leak. Explain the therapy to the patient. Do not put the mask like that, right? He will just throw this thing out. You have to explain what you are doing and what are the benefits of this. And also explain to them that it is going to help his respiration. And if it doesn't work, if he doesn't use it, the patient may require invasive ventilation. So please explain to them. Calm them down. You need time with this patient, okay? Now set the NIV portable pressure ventilator in spontaneous time mode. I would say in spontaneous time mode. Oxygen is initiated. Now first thing, you would hold the mask by own, do not strap it. Just put the mask over the face and see how the patient is breathing, how the patient is accepting it. Okay. Hold the mask for 3 or 4 minutes. Then ask the patient to hold the mask on his own so that you understand now he is accepting it. Right. So that is important step. Friendship. You have to be friendly with the patient. You have to make the patient familiarize with the machine and make the machine friendly with the patient. So that is very, very important. So if you start with a very low setting, right, you can't give them a 16 to 18 pressure or that the patient is not going to tolerate. Patient needs time. So you would start with a low pressure setting of 8 to 4. 8 is the IPAP, EPAP is 4. There should not be a gradient between IPAP and EPAP less than 4. That is important. If it is less than 4, the patient will rebreathe and he will retain CO2. So that pressure gradient has to be maintained. So now first you have to set the EPAP. So you increase the EPAP with a tune of 1 to 2 and see how the patient is triggering, whether he is triggering the machine or not. Right. Once the patient starts triggering the machine, then you set that EPAP level. So that your EPAP is set. Then on the EPAP setting of say 6, ideally in case of COPD, then you start increasing IPAP and see how his respiratory rate is. Right, how is excessive muscle respiration are and how is peroxide breathing. If you find all these things improving and whatever the comfort level of the patient, you keep increasing to that level. Remember, do not keep a very high gradient between IPAP and EPAP. Maximum gradient that you can have is 10 and 12. Do not increase more than that. You can't have a pressure EPAP of 4 and IPAP of 6 to 20. That is not correct. Not more than 10. That should not, the gradient should not be between more than 10. Okay. Now, how do you monitor them? Subjective versus response of the patient. Patient has a smooth adaptation of the patient to the ventilator. He doesn't complain. He is feeling comfortable. Many times these patients go to sleep. That becomes a very important sign. There is elevation of symptoms like dyspnea and they have improved tolerance. They are not, putting out the machine. They are quite comfortable, breathing nicely. They don't have much of a problem. Look at the vital signs like chest wall movement, heart rate, respiratory rate, mental status, and his coordinator of the machine. Machine swings from IPAP to EPAP, and there is a very pleasant sound. It is like Vivek, our Mr. Kohli is hitting a 6. You get a sweet sound of the bat. This is what it is. A very sweet sound of going from IPAP to EPAP. You don't have to look at the machine. Just look at the sound, and the patient is tricked the machine very nicely. Now you also have to monitor these patients in terms of the ABG and the pulse oximetry. Pulse oximetry has to be there all the time. They must be able to maintain adequate oxygen saturation. Ideally you keep the saturation between 88 to 92%. Do ABG after 1 to 4 hours, see how his oxygenation is, how his CO2 is level. Right, especially at the look at the pH values. Right, the pH should improve. CO2 may not improve, but the pH has to improve. That is very important. The failure would be if there is a worsening the pH, the tachypnea is persisting, there is hemodynamic instability, oxygenation is not adequately maintained, there is decreasing level of consciousness, inability to clear secretions, and inability to tolerate interface. So these are the signs that it is failing. And once it is failing, your ABG is not satisfactory, please do not drag this patient off non-invasive ventilation, right? There could be a problem, this could be a disaster, right? Intubate that patient as early as possible. Complications wise, the complication could be nasal congestion, dryness in the nose, oral cavity, gastric distension, eye irritation. Then most of these are, mask related, and you need to take care of those things. Then major complication which I fear is the delayed intubation. Please do not delay the intubation. Do not drag this patient on an IV for long. It has problem in COPD patients, right? A delayed intubation in COPD patient causes difficult weaning. One thing, delayed intubation patient of ARDS and an IV leads to more acute lung injury, right? More chances of mortality. So these things are important. Very rarely it can cause pneumothorax, aspiration pneumonia, and hypertension. Now coming to clinical conditions. If you have got a COPD patient, IPAP would be around 12 to 14, EPAP would be around 4 to 6, and initially start them in ST mode. If you have got obesity hyperventilation, you would need a high EPAP because you want to stabilize the upper airway because of their sleep apnea, and then they need volume. Many times their CO2 is 65, 70, so you also keep a high IPAP and high EPAP, and the setting could be 14, 16, 8, 12. Then in flail chest, again you would need a high EPAP because you want to stabilize the chest, and IPAP they need also volume. So again same setting, 14, 16 IPAP, EPAP 8 to 12. In ARDS patient, maybe many times the CPAP is good enough, you don't need any pressure gradient, 8, 10, 14 you can go up to with CPAP, IPAP, EPAP equal to that. Then in cardiogenic pulmonary edema, you need high EPAP to recruit the alveoli. And of course, many times these patients have got hypoventilation, then you require a pressure gradient, and the setting could be 8 to 15, and in IPAP and EPAP could be 8 to 10. Neuromuscular disorders, 12, 14 IPAP, EPAP 4 to 6 should be sufficient in them. Now coming to the last part of my talk, which will take around 2-3 minutes, this is a very important guideline published in ERS and ATS, latest guidelines published in ERS in European Respiratory Journal 2017. You can note down the reference and read it. It's very, very important guideline. It's a very important guideline. It is by the European Respiratory Society and American Thoracic Society, and it is going to tell you something very, very clearly. Now question 1A in COPD exacerbation. Should an IV be used in acute respiratory failure due to COPD exacerbation to prevent the development of respiratory acidosis? Okay. How many would say yes? Okay. It is conditional against. An IV cannot be used in patients with hypercapnia who are not acidotic. So not every case of COPD exacerbation would require an IV. Right? It's only the patients who have got acidosis, pH less than 7.35. These are the candidates for an IV. Your CO2 may be 55, but if his pH is 7.4, he is not a candidate for an IV. This is a conditional against. But if the pH is less than 7.35, he becomes a candidate for an IV. So please remember, not every case of COPD exacerbation is a candidate for an IV. It's only those who have acidosis. The pH less than 7.35. In COPD exacerbation, the endotracheal intubation, mechanical ventilation should be, we recommend a trial of bilevel and IV in patients considered to require endotracheal intubation and mechanical ventilation unless the patient is immediately deteriorating. So you can try an IV, but if he needs or if mechanical ventilation immediately or he is deteriorating, then it is required. So this is what I have discussed. Question 2A, should an IV be used in ARF due to cardiogenic pulmonary edema? Strong for, so there is no confusion about it. You should use it. Should a trial of CPAP prior to hospitalization be used to prevent deterioration in patients with ARF due to cardiopulmonary edema? Strong for, yes. So while you are transporting the patient from house in the ambulance, an IV should be used. Do not delay use of an IV in these patients. Should an IV be used in ARF due to acute asthma? No recommendation. There is no evidence, but you can try. If it works, it works. If it doesn't work, just avoid it. Maybe keep these patients oxygen, if required, intubate these patients. In immunocompromised host, should an IV be used for ARF in immunocompromised host? Conditional for, yes, because it has been shown these patients who go on ventilation have got higher mortality. So these are the patients where possibly you can delay intubation and persist with an IV as long as possible until it really becomes absolutely indicated, really indicated. So that is one thing. Should an IV be used in de novo acute respiratory failure? Given the set of evidence, we are unable to offer a recommendation on the use of an IV for de novo acute respiratory failure. Now in post-operative setting, should an IV be used in ARF in post-operative setting? Conditional for, we suggest NIV for patient with post-operative acute respiratory failure, right? Any kind of, especially thoracic surgery or abdominal surgery, you can use it. Should NIV use in patient with ARI receiving palliative care? Conditional for, yes, you can use it. Chest trauma, should NIV be used in ARI due to chest trauma? Conditional for, yes, you can use it. Okay, if the patient got a flared chest. In pandemic viral illnesses, no recommendation made. You can try. But you have to be careful, especially in H1N1 cases. If you are using NIV, there are more chances, spreading the risk of infection. So these patients, you have to the contact person have to take proper, precautions. Now for extubation, this is something again very interesting. Should NIV be used in ARI following extubation for invasive mechanical ventilation? Now there are two questions there. Should NIV be used to prevent respiratory failure post extubation? Conditional for yes. Now this is important. We suggest NIV should not be used to prevent post-extubation respiratory failure in non-high-risk patients. Right? Not every patient whom we are extubating should go on NIV. Yes, COPD exacerbation should go on NIV, but not every case of ARDS you are extubating, it may not be required. Should NIV be used in treatment of respiratory failure that develops post-extubation? Post-extubation failure, would you use or not? House is divided? No. You have extubated the patient. Patient has deteriorated, do not drag them, please intubate them, otherwise they will have more complicated, more aspiration. So in a failed extubation, do not try non-invasive ventilation. Try oxygen, that's it. Doesn't improving, intubate. Okay. Should NIV be used to facilitate weaning patient from invasive mechanical ventilation? Conditional for, yes. The NIV should be used to facilitate and weaning from mechanical ventilation in patient with hypercapnic respiratory failure. Should weaning from mechanical ventilation, we do not make any recommendation for hypoxemic patients. In hypoxic patients, there is no recommendation. You may try if you feel, otherwise it's up to your thinking. So thank you very much for your patience. I think I have not exceeded my time. Thank you.
Thank you, sir.